Welcome to this afternoon's Leukemia Care webinar, where we're looking to explore active monitoring, or what many of us as patients know as watch and wait, to understand why active monitoring is a prescribed part of the care process of CLL patients, and to also explore how to use the time involved with active monitoring to better understand and cope with uncertainties and look at strategies that may help you as patients and as the family of patients, to help your patients cope with living whilst on active monitoring and the uncertainties that this leaves with patients. So a little bit of housekeeping. I just want to let everyone know that you're unable to turn your cameras on and chat and ask your questions in person. I just suddenly realized something that I need to just check on chat for you. Apologies. Please use chat to introduce yourselves, say hi, post any questions that you might have for the panelists. And after the doctor, Professor Francesco, has finished his talk, and Bryony, who's a clinical nurse specialist, has finished the talk, we will look to address questions in a Q&A discussion. Apologies, now chat is open. I've just had to unlock that. So I'm sorry to direct you there, but hopefully that's now working for everybody. If anybody out there can post a question in chat, that'd be terrific. Just to let everybody know, we're also streaming live to Facebook. So if you're watching from Facebook, if you want to pop any questions to the panelists, just put them in comments underneath the video screen on Facebook, and a colleague at Leukemia Care will be collecting those so that we can actually field those for you. I'll introduce myself if you haven't met before. My name's Nick. I work in the advocacy and support team at Leukemia Care. I'm also a CLL patient, have been for many years, and I've spent quite some time myself on active monitoring, so I do have some understanding on that, and I look forward to the discussion with our panelists afterwards. So I think this is as good a time as anybody now to introduce our panelists. If I start with Bryony. Bryony, could I introduce you? Would you like to introduce yourself and share your connection? I seem to have lost your camera, Bryony. Are you with us? Oh dear. Francesco, over to you. Maybe you could introduce yourself and then go straight into your talk, the hematologist talk about active monitoring. And hopefully Bryony will have ironed out any technical questions.
Right. Hello, everybody. Thank you very much for to Leukemia Care for inviting me for this meeting this afternoon, which I hope will be helpful. I have given little time to wonderful Nick to think how to better present this talk. So it will be, in a way, a private introduction to how I, as an academic doctor, perceive the importance of watch and wait for patients who are tagged with the diagnosis of CLL. And what I would like to have as an outcome is really to open the discussion for questions to which I will like to answer. So forgive me if the presentation won't be as lay-friendly as it should be, but Nick will interrupt me at any time, and the discussion can be made at any time. I am just trying to link. I'm just trying to see how to
You find your share
present,
screen?
how to share the screen. Yeah, and then I will stop here.
So what I was going to suggest is that the idea is maybe to, after the talks, to have to field some questions to you. But if there are any burning questions during it, I will raise those with you, Francesco.
Right.
And if
What
there is
I-
any language that is maybe too technical,
You interrupt me.
forgive me if I interrupt, just to ask you to qualify those. Yeah.
Right.
Excellent.
So,
We now have your slides.
so really the goal for me today is to try and understand what active monitoring means. While I was speaking with Nick, I've come with the idea of a different wording that we will that I will show at the very end, and for which Nick will have a laugh probably. But the important thing is, I think, this one. When we talk about chronic lymphocytic leukemia, can you see the screen? Do you have to?
Yeah.
When we talk about chronic lymphocytic leukemia, we are talking, of course, about the most common type of leukemia in the Western world, in the adults. When we read about leukemia in the newspapers, we're talking about completely different conditions quite often. Not always, but quite often. There are different types of leukemias. Some are called acute leukemias that are rare and dramatic, and others like CLL, which is a condition chronic, which means indolent, which means slow pace, or actually quite often no pace. So one of the big questions that Nick has raised is if I can interpret it in a very personal slang. Wait for what? There's no need. In many occasions, there is no need to wait, and the doctors need to watch. So let's see what we mean for that. The first important point is that of all chronic lymphocytic leukemias, only 3 out of 10 in the lifespan of individuals with CLL will require a treatment, will need to receive actively drugs to change the counts and the condition of the individual and the medical condition of the individual. In the other 70% of patients with a diagnosis of CLL, there's no need. There's really no medical need. Patients will have a lifespan identical to the others without the diagnosis of CLL, and will have complications in their life which are very much the same those who do not have a diagnosis of CLL. So there is really a big chance of generating a red herring for the individuals who come to hospital, has been given a horrible tag on their shoulder, and instead they shouldn't wait, they shouldn't worry. Where is the problem? The problem is in the fact that generally, to the common hematologist and to the common doctor, chronic lymphocytic leukemia falls under one single umbrella, while chronic lymphocytic leukemia is an extremely variable condition with an extremely variable outcome, where there is a little incapacity from the diagnostic, from the classic diagnostic tools to understand which is the one that is going to require treatment or can cause trouble, and which CLL will not require treatment, will not cause trouble to that individual. These cells, which are called lymphocytes, are small cells with a dense chromatin, meaning that in the majority of the cases, they will make no fuss, they will make no trouble, they will not divide, they will not proliferate. This is what we find in large amounts in the peripheral blood, which makes the diagnosis, together with what? Together with another test that is called immunophenotype. This is a test in which cells are put together with markers. These markers can recognize different molecules on the surface of the cell, of the CLL cell, and they are given numbers, CD1, CD2, CD3, CD4, CD200, CD5, CD19. And CLL cells are characterized by a monotypic, by an individual phenotype set of characteristics that is given basically by three markers. One is the expression of something that defines B cells, those cells that will produce antibody to fight infections, and this is CD19 or CD20. Another set of markers that are typical of that expansion called CLL, and it is this marker, CD5, and another marker, CD23. All CLL cells look like this. So is there any heterogeneity in that? A little, but not sufficient to explain why some individuals will have symptoms and many others will not. So
Can I ask a question, the heterogeneity.
So heterogeneous means some patients, I don't know how to say that. So there will be a lot of variability, of variations between one patient and another in the way they will expand their cells in the peripheral blood, or where the CLL cells sit, which is the glands, these little tiny lymph nodes that we often look for in patients in the neck, under the axillary regions, or in the groins. Some patients will have it, some patients will not have it. Some patients will have lots of lymphocytes, some patients will have very little amount of lymphocytes. This means heterogeneity.
I understand that. So what you were describing in simple terms earlier, that with the immunophenotyping, the CD5 markers and the other, that's essentially everybody has that same barcode for CLL. It's like
everybody has got this identical barcode. That does not explain that some have glands that are bigger than another individual, or does not explain why an individual has a bit of anemia or a lot of anemia. The cells are all look the same. They look the same, homogeneous. Cells are homogeneous, look the same. Patients are all one different from the others. Patients CLL is one different from the other, heterogeneous.
Okay.
Why that could be? We know as doctors, as scientists, that this is because there is a group of cells in the glands of our body, if there is a CLL, that will have the capacity to divide, to proliferate. And what we do in the lab, we look for these cells by a marker. Now, take it as it is called, like I'm called Francesco Forconi. This is called Ki67, which will stain those cells that divide. It's not easy to see it here, but think that every black dot is a cell that has divided, and all the other pale dots here are cells, millions of cells that have not divided. And this example here is showing a CLL lymph node with a lot of cells that have divided. And when we say a lot, is in the figure of 1/10%. So it is these cells that provide a different type of heterogeneity, a different type of variations in CLL. That is, some of these dividing cells on the division will make changes in their DNA. These are called mutations. And some of these changes may make the cell more aggressive or not. This analysis of the genetic changes was very important when the treatments in CLL were only toxic chemotherapy. Now we are going away from that classic way of chemotherapy, where we were throwing bombs onto the tumor cells and we were hitting anything around that, even the good parts. So it is possible that these changes, these mutations, are no more important. What is important instead is to remember how these cells come from a normal type of cells called B cell, that on the surface has these Y-shaped molecules called B cell receptor, BCR. Anyone who goes to the clinic with a diagnosis of CLL now hears a lot about this word of B cell receptor inhibitors, BCR inhibitors. The BCR is this molecule that sits on the surface of these cells that normally has the goal in this dig here to recognize viruses, bacteria, antigens of any type to fight infections. The B cell receptor of CLL is exactly the same, but it can be in two shapes. One without changes in the site where it recognizes viruses and bacteria. This is called variable region. And another one with changes in this region. Why is that important? To the doctor, it tells us where the tumor cells is coming from. It also says that there are patients where there are these changes. It's called mutated CLL. I will call it MCLL from now. That within the years, these are months. So 240 is 20 years. Here we are around the figure of 30 years. The time when a diagnosis is made is the time point 0. And on average, individuals with CLL here at this time point 0 have 72 years, more or less, with a lot of variations here as well. So if you think that this percentage here represents at each time point the proportion of patients who have needed or need a treatment, you will understand that there is a big chunk of individuals, here it's around 40% from this analysis done in Southampton, a big chunk of individuals will never need treatment. 72 years, 92 years, here we are around the figure of 100. Yeah, so there are a lot of other factors that will push an individual to have treatments, and it may not be CLL. So this is why, one of the main reasons why we do not want to give chemotherapies to those who do not need it. There are a bunch of other molecular factors that I will not describe, but another important factor in CLL is that we have said that during their natural history, eventually there will be genetic mutations. We, as human bodies, acquire lots of genetic mutations and do not necessarily get cancers. It's in our nature, any cell that divides in our body, and we keep changing them from the cells of the skin to our hair, anything changes in our body, more or less, over time. So within changes, we will acquire a lot of mutations. CLL cells don't do anything different. The point is that they have probably a higher propensity in the later stages to get genetic mutations that can impact in their ability to proliferate more. Why does that happen? It's in their nature. And the second aspect is that if you give a treatment that upsets these cells, tumor cells are designed to escape any of these treatments. That's their nature. They want to survive. They always want to survive. And they will use any tools to avoid what we try and do to block them from surviving. So therapies gives a reason to these cells to become more aggressive. So let's wait as much as we can for the therapies to be given. A third component is that one of the main reasons why patients with CLL may have trouble, may have problems, is that they get infections. The infections is due to the fact that their their defenses, their protection against germs is weakened with the CLL. And the weakening comes together with the amount of disease that is in our body. So the more disease, the more immune suppression. At the time when a diagnosis of CLL is made, which is generally in the early stages, when the stage means stage 0, little disease, stage 4, lots of disease. When we look at the condition, the immune system in the early stages, and we compare it to individuals who are healthy, here I call it normal, not that these other individuals are abnormal. I think it's weakness of the descriptions. And we look at antibodies. These are called IgM, IgG, IgA in the serum, which is the first one of the way by which B cells protect us from infections. And we look at the amount of these antibodies on this y-axis. So we see that in the early stages, there are some antibodies that may drop. So the earliest stage is called rise 0. We can come up to the definition of what MBL is, but we will discuss it later. Some will have a little drop in the early stages. But if we look at the important antibodies, IgG and IgA, really at the beginning, it's not a massive difference. So why do we need to give treatments to individuals who have no impairment at that stage or have little impairment of their immune system? As we know that giving treatment to these individuals, whatever type of treatment we give, for example, the inhibitor I was talking to you about, the BCR inhibitors, and we go and look at one common infection, call it, since it's so popular, COVID, and the antibody responses to those infections, we see even the novel treatment can indeed impair the immune responses, the ability of our body to generate antibodies against, for example, here, COVID. But in general, this happens for any type of treatment. Again, a reason why we want to stay here. We don't want to rush in anything that is not needed and will make life more miserable for those individuals who are on treatment. There are lots of buts here, by the way, because I'm showing to you the one side of the medal, why treatment is not needed. So this is the topic today. There is obviously reasons why treatment is needed, and we can discuss it today or on another occasion. So that's the other big component. The third point is, so how can we anticipate? The individuals who have a diagnosis of CLL are from those individuals who have, depending from the place where you have been diagnosed and the expertise of the doctor, are those.
Sorry to interrupt. These slides are very hard to see and very technical. I have a few comments there. I think.
So I will want to make a verbal statement. So the patients who have a CLL can be with a lot of disease or can be with a minor amount of disease. The majority are those with a minor amount of disease. Those patients nowadays sometimes are also classified out of CLL, and they're called monoclonal B-cell lymphocytosis. Those individuals have no changes of the immune system. The immune system works properly. So no need for treatments there. But we need to understand from a doctor point of view, who is the individual who will progress and who is the individual who will not progress. This figure is a complication, but it is what doctors have been using for several years until the time of chemotherapy, certainly. And it tells us who are the patients at low risk of progressing, high risk of progressing, this red line, and intermediates. It was made on a complex set of information that comes in the clinic, which helped the doctor to say these patients will never progress. Yeah, again, think about this is 10 years, and up to 70% with CLL will never progress to require a treatment. And they want to add that these 70%, this 30% here who requires treatment will benefit a lot from that and will fall into another category, the PIFU category, as we were discussing it with Nick, if he wants to bring it back. But it is a complex thing. By just looking at one parameter in a big group of investigators internationally, we have managed to see how, by looking at the lymphocyte count, by looking at the number of lymph nodes, of palpable lymph nodes, and just one molecular characteristic, the mutational status of the immunoglobulins, we can define those individuals who in their life will ever progress or not. Blue will never progress, red will progress. So by a simple analysis with the specialist, actually, what nowadays patients can do in an era of precision medicine, which is another component and another type of discussion, we certainly can move from thinking wrong, I would say, into a wording that is watch and wait, and another which is, I called it watch and DC or DNC, watch and don't care. Let the doctor watch and just get on with your life, provided that the doctor reassures you that you fall into a category which will cause problems. We can say that. And then we can tighten down on who are those individuals who actually if they need to care, they let the doctors care on what they possibly need to do in their lifespan. I think I would like to stop here and be open for any questions, because otherwise I have already risked to fall too technical on 2 or 3 occasions, and be open for any questions that you want to raise.
Thank you, Francesco. Can we hold on the questions until after Bryony's just been able to give a chat? Hi, I was going to, I mean, a couple of questions that are immediately jumping out there is that obviously the uncertainties when everybody is diagnosed with leukemia and the asymptomatic people without symptoms is the larger group at diagnosis, and the uncertainties until all of these prognostic tests are carried out. And if they are able to be carried out, patients are living for a long time with these uncertainties. So I'll come back to the questions about the prognostic tests and what is guidelines and what can patients learn, and what watch and wait can give. But I think the most, from a practical point of view, I'm looking forward to Bryony's talk, as Bryony is a clinical nurse specialist at Southampton, and she provides the supportive care to, to provide the care and support for patients on active monitoring. Bryony, are you able to see us now?
I can see you, Nick. Can you hear me?
Yes, we can hear and see you now. So well done. You've managed to get that fixed.
Yeah, I'm sorry about that.
You put some slides together. I was just going to ask you, Francesco, would you be able to take your slides down? Thank you. I'll see if I can find your slides there, Bryony. Well, that's good news that you're back with us.
Yes, I had to find another computer. Mine just died, I'm afraid. But I can see and hear you now.
There we go. I think I now have them.
Yes, mine are very basic.
Are you able to see the slides, your slides?
I can, yes.
There we go. So if you'd like to introduce yourself and share the role of the clinical nurse, your role in providing support to patients once diagnosed and living on active monitoring, and your perspective as well.
Yes, of course. Hi everyone, my name's Bryony Tyrrell. I'm a lymphoid clinical nurse specialist at Southampton General Hospital, and I work with closely with Professor Facconi, so caring for CLL patients. So if, like I say, very basic slides, but so if we move on to the first one, Nick. So basically my role, as I said, is working closely with the consultants to support patients, well, from their diagnosis through, obviously, if they do have treatment, facilitating treatment. But for those that are on watch and wait, or as we like to say, active monitoring, I provide a link to the medical team. I advise patients if they have symptoms, or I'm there if they are starting to, worry. I signpost to areas in the community or charities to help both physically and psychologically with problems. And if there are any issues with the hospital clinic appointments, things like that, I can then sort problems out and liaise and be a contact within the hospital. So it generally pretty much sums up my role. So if we move on to the next one, Nick. Okay, so I saw this photo and I actually thought this summed up what I'm sure a lot of people feel when they're first given the diagnosis. And it's very much, it's a personal thing. It's different for everyone. Some people sort of, it takes a while to sink in, and it's such a frightening word, leukemia. And it's associated with, a lot of negativity. But what my role particularly is to try and support people through that diagnosis, and to help them live well, live normally, to get through that time of uncertainty. Everyone has a lot of questions that quite often they're not so comfortable to ask the doctors, or they worry about taking time or not understanding. So that's where I come in, myself and the support workers, to just help people to cope with that diagnosis and to live well with it. And like I say, it's different for everyone, and it's an individual journey, and we try and help everyone on an individual basis. So if we go to the next one, Nick. So this again is very, very basic, but I actually felt the picture. I think the picture says 1,000 words. Really, it's to ensure that people can live the best they can with this diagnosis, especially on watch and wait, because I can imagine it's like having something hanging over you. It's like having a sort of cloud there that's always in the background. You know, you may not feel it, but it's always there. And I feel that anxiety is probably the biggest issue that people have with watch and wait. And that's something that we try and help with. I think fatigue as well can be a symptom that people get with that watch and wait. And sometimes I feel that the anxiety and this heavy weight on them is part of that. And I feel like they sort of exacerbate each other. So we try and advise, particularly, I would say, diet and exercise, healthy diet, you know, healthy weight, not smoking, not drinking too much, staying active but not overdoing it. So these are all things that we try and encourage patients to do, and we really do see that it benefits people. But it's trying to understand that mindset of you can live well with this diagnosis, and many people do, and it's not something that needs to change your life or bring you down. So if we go to the last slide, Nick.
Apologies.
Oh, that's all right.
For some reason, it's stuck.
Yeah, brilliant, thank you. So just I wanted to finish here. Obviously, it's all well and good saying you can live a normal life and don't worry, but actually, you need support around you to do that. So the haematology team, such as Prof. Bocconi, myself, we're always there. You know, sometimes we're busy, but we'll always get back to people if they have worries, if they have concerns, if they need support. That is what we're here for. I think it's fantastic if patients can speak to other patients, you know, quite as we're doing now, because although we can advise on the medical side, we haven't been there ourselves. So it's good to get speak to other people and find out how they cope with things. And then obviously you've got the fantastic charity support, so the counselling available, financial advice, lots of options, support groups, like the Facebook page. You know, there is a lot out there, and you don't have to go through it alone. So I added in the leukemia, the watch and wait and worry, because I think that's an excellent campaign. And just have a look at the advice that's on your website. It's very, very helpful. So I think that pretty much sums up what I wanted to say, just to try and encourage, you know, patients to live well and not worry.
Thank you, Bryony. I'll stop sharing the slide. So from what we seem to have talked about so far is that the majority of patients when diagnosed with CLL will be asymptomatic. They will not have symptoms, but they will be told they have leukemia. And there are tests that potentially can be done that might in time give an indication of whether somebody is going to progress or not, or time itself would be the indicator of how stable somebody's disease is. That doesn't take away all of the uncertainties and the worry. You've been told you've got leukemia, and it's counterintuitive that you're being told it can't be taken out, it's not going to be dealt with until it has to be. And that's very hard for patients to understand. And of course, you've explained that there's no evidence that treating earlier, Francesco, will actually improve the long-term prognosis of the patient. So therefore, I think it was once explained to me, and you explained it slightly differently, is you don't want to wake a sleeping tiger, which is effectively in the days of chemotherapy what could happen. Maybe from what I've gathered with the discussion, that technology is changing, treatments are changing, and they may in time be introduced earlier. But in the meantime, if you're a patient, you're diagnosed with what you're told is a chronic condition. Chronic means long-term, and it's an incurable, essentially, but treatable condition. You may or may not need treatment. And it's all very hard to understand. And I'm going to come to some of the questions that have been asked. And on the other hand, if you are at a centre of excellence, not a district hospital, then you will have access to a broader care team, a clinical nurse specialists like Bryony, who are there to provide supportive care to help you through the diagnosis process and through your journey, and are there for you. But it's a little bit different for maybe those that don't have access to a clinical nurse specialist, and hence that's part of the Watch, Wait, Worry campaign, explaining a lot of the issues that are there for patients. So really, if we can address, maybe we can address some of the topics. I just wanted to be clear from you, from a clinical point of view, what is important when you're on, so if you are diagnosed and you don't have any symptoms and you're in the process of acting on what strategies need to be undertaken from a clinical point of view to make sure somebody is prepared for their journey, and what can patients do to maybe best prepare themselves for their journey? Have you any thoughts on this, Francesco?
So this is a specific question which has a very broad answer. Again, it comes down to the point that we tag an individual with a condition that may be a disease, maybe a cancer in its own terms, the minority. And another situation in which it's really like having a mole on your skin, but you're not able to distinguish it from something that needs to be removed. So the majority of lesions that we have on the skin are not cancer, they're nothing. It's just that we are, as doctors, inaccurate and unable to discriminate. This is a black spot, don't worry, from this is something that needs to be removed. So first point, what is the most important thing? There is a very unfortunate thing that is called time, that is probably the most important of all. Able to explain to the individual with that L word put in front of them, to understand that it may be something important to monitor or to treat, or it will likely be something that needs just to be taken care by a doctor who needs to take care and remove. That's the task of the doctor and of the entire team, to remove those anxieties that are not necessary. Time is unfortunately required for two reasons. It does show, to some extent, with the common shared technology around any hospital in the Western world, including district hospitals, it offers it shares the technology sufficient to say whether there is something growing up, something that at some stage will be required. That's by far the most important thing. And in clinical terms, it is called lymphocyte doubling time. In more specific terms, to the specialist, it means see whether there are changes in the blood. That also includes some other parts of the blood. By far, that's the one shared way, most important to understand. And it is very unfortunate that during that time in which we need to build the kinetics of that condition, during that time, we can't change much. The information is not there to, the scientific information is not there to make any strong, valid, proven statement. However, the way the NHS system is structured now allows centralization and is designed and moves towards centralization. The most simple way of centralizing information so that district hospitals and university hospitals can do is through multidisciplinary teams meeting and concentration of diagnostic hubs for all the hospital of the districts in one place. This is commonly a university hospital, but it doesn't necessarily need to be. The example in the district of Southampton and the Wessex area, we do the molecular diagnostic still in another place, which is Southampton, which is Salisbury, for example. So this is another very important thing. Will it change and remove the anxieties? No, but that's the effort of the system to provide a homogeneous way, a similar and identical way to look after patients wherever they are. In some places it works, in some places it doesn't.
Thank you for that one, Francesca. So, in short, you might not be seeing an expert consult somebody who has a special interest in CLL in a district hospital, but they ought to be consulting with an expert as part of the multidisciplinary team following your diagnosis. And is that the general web? And the other thing I was taking from what you're saying there is that time is probably the greatest prognosticator when monitoring a patient. So I just wanted to follow on. We've got one question that's coming from another channel on there, is how frequently when somebody is diagnosed would you expect them to be seen, and what does frequency of consultation appointments mean?
So we have shared patterns of we have patterns of monitoring patients that have been standardized according to guidelines. But here there is another variability between one center and another, which depends on the resources that those centers have in order to predict whether a patient falls into a category, into the green, red, blue category, those categories in which we can identify the risk that the patient is progressing. These, in a virtual system, would really require that the non-specialist does send their patients or describes their patients and their material that is used for the diagnosis to those centers that can do the full characterization and have the specialist expertise in feeding back to the non-specialist doctor. That is what the health system should be working more back on, and that's what the natural health system should be. can we resolve that in some way? That's a bigger question. For what happens in Southampton, we have the privilege of characterizing the risk of those individuals quite rapidly. And for us, time can also mean, on occasions, just 3 months, to see what happens within 3 months. And during those 3 months, from the diagnosis to the next time that we see an individual, to have all the pieces to say, look, your CLL actually is stuck the wrong way. It's something less important than that. Unfortunately, we don't have the expertise and the knowledge to tag it in a different way by technical standards, but your condition is not a disease, it's not something that will cause you problem. In some circumstances, we can say that. And those patients may be offered to be seen once every year. It will be the relationship with the GP, the individual relationship of that specialist that will allow, facilitate, and reduce the anxiety on the specific individual. And that is something that changes from place to place. There are other individuals in which there are prognostic parameters in which make the doctor think that there might be a high risk of progression in the short term. When we say short term, in those cases, we are talking about figures of every 3 months, differently from leukemias, which means figures of days or weeks, acute leukemias. So within those 3 months, between one appointment and another, we will be able to define better the time frame around the needs of the patient on when maybe a treatment is needed. Then there are lots of intermediates, a huge amount of intermediates. And these intermediates are, unfortunately, in every single individual hospital, very much conditioned by the abilities of those hospitals to work with their workload. This is not something patient-related. This is something that is often NHS-related. It does depend on the individual hospital. In Southampton, we like to see and to advise on a general basis for those individuals who monitor monitoring, as opposed to those who may not even need monitoring, to see them once every 6 months if they don't need treatment in the watch and wait. If we are able to develop other mechanisms of monitoring, and we are developing them in Southampton, they may actually need to do some blood tests and have an interface in the hospital that they don't even see, in which those blood tests are seen, and the patient is called should they need to. That's called patient-initiated follow-up that people like Bryony and others are developing in this hospital. But that's just an example and an anticipation where we may aim to go.
Okay, thank you for that. So I'm just trying to sort of summarize what you're saying there, that during the first stage of diagnosis, it takes, you would expect to be seeing somebody every 3 months. Maybe the first 2 visits will take the time for you to assess the parts of the jigsaw puzzle in terms of what information you can get to get some prognostic indication. Then you would expect somebody that wasn't diagnosed, that was very stable and very early CLL, maybe to be put out to a year, as you just said. That's part of the problem, isn't it, for patients who are diagnosed with a leukemia and then they may not have their connection with the support. And I think that's a big area where the charities can step in to provide support if people and connect patients with other patients and other services to help with understanding living with a stable, very slow progressing or not even progressing condition. So that also is the issue that patients are often referred back to primary care if they're very early and very stable. So I'm just going to move on to a few questions that very briefly, because I noticed we've got time.
Quickly, however, to that point is yes, there are some patients, individuals, who are actually, and I'm quoting, for example, Southampton, are sometimes said, don't leave our clinic because we want to be 100% sure we are learning from you. So there is the rebound effect that those individuals are helping the system rather than being discharged as they may deserve for what we know at the moment. So
A
just
few
positive
questions.
on that.
Thanks, Francesco. I'm going to whiz through a few questions because of some technical issues. We might overrun by 5 minutes. A question for Bryony. I mean, what are the 2 or 3 biggest issues, sort of in general terms, that patients with watch and wait raise with you as a clinical nurse specialist, maybe rather than with their consultant?
So I think that's why I mentioned anxiety and fatigue in my slides, is because those are the 2 biggest issues that I find that patients speak to me about. So I think dealing with that anxiety, like you say, of that watch and worry, and that is where I do, obviously, just talking to patients is can be reassuring for them, but it's not something obviously with it that we can do every day. So that's where I think the peer support and the charities come in. We're very lucky we have a support worker from Leukemia Care in our clinics that I will refer patients to, and I know she's helped a huge amount of our patients. And the other thing, like I say, that does come up is that fatigue and dealing with that. And sometimes it's difficult to tell whether that's related to CLL. I think quite often it's not, it's actually other things. But I think when you have a diagnosis like that, you tend to link everything back to that when actually quite often it's actually unrelated. And at the moment we're having issues with patients contacting their GPs. I get a lot of people contacting me because they're not able to get a GP appointment. They're not able to even speak to someone on the phone quite often. And I know that because when I try and speak to GPs on their behalf, I have exactly the same problem. So it's ongoing problems, but I think those are the 2 main issues on the watch and wait pathway.
Thanks, that's very helpful. Maybe just following on from that, now, is there anything that patients should be looking out for themselves? You know, if that's part of the question. There's somebody's raised a question, and maybe this is for both of you actually. Somebody that's under the care of the GP has got lymph nodes now present in 4 different areas. I know there's something to do with they have to be on different sides of the body, I seem to recall, but this person has just, you know, I know it's a personal query, but it's an interesting point, is person's got lymph nodes present in 4 different areas. Should they be seeing their hematology, referred back to their hematologist? Have you any thoughts on things that patients should be looking out for or not looking out for?
Is that for me? Or
either or. Francesco, what's your answer about lymph nodes?
So again, the point, the critical point here, very important point, is whether those many lymph nodes that by definition should be occupied from the start of diagnosis are not if how many they are, but if they're changing quickly in their characteristics. So with an individual who has a diagnosis of CLL and has had small lymph nodes of less than 1 centimeter in the neck, in the axillary region, and in the groin, they are no different from an individual who's got no lymph nodes palpable to some extent. However, those individuals can have a better understanding of what is happening because they have something measurable. So the point there is how quickly, if and how quickly those glands change in size, any of them. That is the question. If they change, then a specialist must see them. If they have been lingering there in an individual who's already been given a diagnosis, then that's not important. An individual with mononucleosis with no diagnosis of CLL will have big glands, will have a big spleen. They don't have a CLL. Will it have to be seen by a specialist? It will have to be seen by a doctor who knows their job. That's what they need to do.
Thank you very much.
Answer.
That does add a bit of clarity there. I'm just going to, we've overrun slightly, but we've got quite a few questions that really, I'm assuming somebody's asked a question, is early stage CLL 1 and 2? I don't know if this is a UK person on the call, but could you explain how CLL is, just very briefly, just what are the early stages? How is CLL staged?
So the word early technically is used to measure not something in time, but something in load of CLL cells. So we have to be careful when we say early CLL. However, in technical terms, technical medical terms, it is actually stage 0-1, according to RAI classification. So that time when there is a diagnosis of CLL, there is no anemia, there is no thrombocytopenia, there is no splenomegaly, and the worst scenario is that there are glands around or not. If there are, it's called stage 1. If there aren't, it's called stage 0. So the number of glands is not impacting on the stage much. It is other aspects.
Thank you, Francesco. I hope that answers the question. Whilst we're on this topic, there's several more questions.
Having one gland or having 5 glands felt doesn't change the stage.
On a similar line, a couple of questions on this theme. You mentioned an indicator of potential need for treatment might be doubling time in terms of the increasing lymphocyte count. What are the other indicators that might mean that treatment's approaching?
So
for example, I was just going to ask, answer the question. The second question that dovetails into that is somebody that's been on watch and wait for 10 years, has had no problems other than a few lumps on their neck, but now has got to start treatment, and that person's quite terrified, and I can understand that myself. But why has that person probably now needed treatment? So there are other indicators of when treatment might be needed. Could you explain what they are?
So this is a tricky situation, because we are assuming that something that we classically anticipate has happened to that individual, but might be the situations why treatment is needed are very much variable and need to be discussed between the specialist and that individual patient. So I want, in general, and in general, it's never the right answer. So it doesn't apply to the individual who made the question necessarily, but in general, it happens that an active CLL or a progressive CLL is the indication for treatment. Active means that either the white blood cells increase, the lymphocytes in the blood increase rapidly. We're talking rapidly about within 6 months to double up. And we are not talking about increasing from 5 to 10, according to, but it is increasing from 50 to 100, or in units, 50,000 lymphocytes per microliter into 100,000 lymphocytes per microliter, not 5,000 per microliter into 10,000 per microliter. That doesn't mean anything. The other parameters are how big the glands change, how quickly the glands change within these 6 months. Do they double up in size or not? If they do, they need to be seen earlier by the doctor, by the specialist. If they don't, there is no indication of activity. Active. Other point is generally these things, doubling of the lymphocyte counts or doubling of the size of a gland, comes with symptoms. These are those symptoms that suggest that there is something cooking, making heat in the body. So heat waves, to distinguish for another million of heat waves that, for example, in a woman who's in their 40s or in their 50s can have, or an infection that can give that. Sweating, loss of weight are indicator of something very active happening in the body. So that if there is not an infection, if there is not another reason, it might be the CLL that is active. And if it is accompanied by other signs that those that I have described. This in general is what is happening when there is an active disease. Progressive means instead that it changes from one early stage to a late stage. So there, for example, we're talking about an individual having from no anemia to anemia, from no spleen to a big spleen, from platelets being normal to having platelets that drop down markedly. There are gross changes. That's the advantage that we have in CLL. Little tweaks are meaningless. Big changes can be.
Thank you very much, Francesco. And I think just as we begin to finish this webinar now, I will share some information that help signpost and point people to either information booklets or to peer support and groups that can help. There's just a couple of questions that have intrigued me. Somebody who is considered, how do low-risk CLL patients, how careful do they need to be around family and members and work with regards to infections and colds, etc.? I think I can relate to that. You know, I remember when I was first diagnosed in the very, very early stages of CLL, and I heard that there was, as you pointed out, that CLL patients can be immune compromised. I could hear somebody sneeze all of a sudden halfway down the street. And I became very anxious until I understood over time how often I was getting infections. But I'm wondering, is that the answer to that? It depends how frequently you're catching infections. That it does take a bit of time to get to know your body. Do you have any thoughts around this area? Because obviously with COVID now at the moment, and I just want to point out to everybody, there's a couple of COVID questions. We can't really address them in this webinar because we will, I can signpost you to the Leukemia Care website where we have our most recent COVID webinars. But Francesco, any thoughts around that area about infections?
Yesterday, we had an individual who came with his wife, actually a young, relatively young man, 56, who has a lymphocytosis and is likely to have a CLL. That individual has never had an infection, and he was sitting next to his partner, who instead had COVID twice. Certainly the partner has no CLL, nothing of that, has not had any other medical problems in the past other than the 2 COVID infections. The individual who is at risk, who is immune suppressed, has never had infective complications. So you're quite right in what you're saying. We do give, as doctors, a technical answer defining CLL as a condition associated with immune suppression, with a reduction of the immune defenses against infections. But that's a broad statement that depends on many other factors that as specialists we will have to look at. Oh, you're very much right that having a retrospective answer, as you have done, Nick, but how many infections do I get in a year compared to my wife or to my friends or people around? That is indeed a parameter telling us how immune suppressed the system is. And I think it's a reasonable approach for the fact that we don't have technologies to say what it is really the risk of infection for an individual as compared
It's a
to
very
another.
difficult one, isn't it? It's a very difficult one if you don't know what level you may be immune suppressed. So I think everybody's learned during COVID about hand washing and avoidance techniques if somebody else is unwell. Before COVID, as patients, this is what we were taught to do. And the winter months, if in your hemisphere, if you're in the UK, there are more contagions like influenza or RSV, respiratory viral syndrome, and now we have COVID. It's very much a challenge.
It's surprising that we have said that we have learned to wash our hands with COVID, but I thought that was a general rule.
I'd like to. I've just seen a couple of questions going. I've overrun, and I'm going to get shot for this, but I'm just seeing if I can actually find chat at the moment. A couple of questions, one of which is how frequently would you expect people on watch and wait or in active monitoring to be scanned, to have full body scans? Something I wouldn't have thought was a very frequent thing unless it was pre-treatment or unless there were symptomatic issues that were causing concern.
So if you speak with Kanti Rai, who's the one who made the classification, Rai classification, he would answer to you, and I hope I don't misquote him, never. So we have advantages in technology and we do want to exploit them. And certainly they reduce anxieties. If we are unsure of what the answer should be to patients or what the patients want to have. But CT scan have their disadvantages, and in the balance, it should really be the clinical interpretation with the physical examination, with blood counts, that in the largest majority of individuals is sufficient by a specialist.
I thought that might be the case, but thank you for clarifying that. Now, this is an interesting one, and it's a difficult one. What is the disadvantage today of being diagnosed at a young age, under 50? Now, if you'd have asked that same question, if I'd asked that question 10 or 15 years ago, I might have been frightened to ask that question, not wanting to give negative information. But today, if you're diagnosed, I mean, I was diagnosed at 49 and I was 60 a couple of months ago, not so many months ago. But your thoughts on this question, because I remember what the old data used to say.
What did they say? Because it's a tricky question and it's a
Well, I remember the Israeli data going back 10, 15 years ago, that younger patients diagnosed, people diagnosed at a younger age were more likely to die because of their CLL rather than something else.
So this is, I think,
we only had chemotherapy. So I'm just asking,
So first, I would like to stress that it is unfair to make a general statement. Very, very unfair in this meeting, in this community. I think the one important objective point, I would say, rather than important, is that in principle, all patients with a diagnosis of CLL are projected to progress. So this statement is scary, I know. What we have to add to that, we don't know how quickly they will progress. Actually, it's 95% because there are patients who actually go back, and this was studied by people in the UK by Birmingham and Leeds, of a population in which CLL regresses. So I'm actually inaccurate. But given that statement, it is really how quickly they progress. If we set an average way of progressing, the unfortunate answer to individuals who are diagnosed before 50 is that they have, compared to individuals who are 72, they have 20 years more or 25 years more to find their CLL having progressed quickly enough to see it progress during their lifespan. So this is the objective answer. Then we can make a lot of discussions around that. And my honest answer is that in our cohort of 1,000 patients, we're actually looking into it to see what it means having a diagnosis earlier. Other studies have been done. Comments can be made, but I'd be reluctant to make any more comments than these because they might be wrong.
Okay, it's a difficult question. I'd like to look at it from a patient point of view with what I know today. And I would like to see there being a lot more hope there because, as you pointed out, you might have been diagnosed as a very asymptomatic patient. You might not need, you might progress very slowly, as you've just been saying there. So you might not need a first treatment for some considerable time. And being a younger person, that is more likely to happen, but you might not be the progressive patient. But now we have treatment.
I didn't say
I was going to say before, I was going to say, but now we have treatments that are able to provide, that are less toxic, with better safety profiles, that don't impact so much on your future life, quality of life, that can bring about remissions, strong remissions. And then there are many more treatments available. So what I was saying is the landscape is very different today, isn't it? So there's a lot of room for hope that just because you're diagnosed young doesn't mean that you're in a worse position than anybody else.
Not at all, actually. So the answer to your question was, what is their chance that they may progress? I didn't mention what is their chance that they may have significant impairment onto, for example, let's be crude, their life expectancy. We don't know anything about that. It doesn't change the perspective. What you
the
are
question
also
really was, what are the disadvantages of being diagnosed young? Obviously, there's the mental anguish, there's the torture of being diagnosed with a leukemia, and you live with that possibility for a long time. But is there anything more substantial that you would pin on it now?
The one thing that I would stress, not only that there are better treatments, but what you did say is that treatments now are more than before. Yeah. It's not that we are binning all the treatments of the past. In some individuals, in their very early, when they are 80 or 90, we can still treat them. And also with all type of treatments, which are still pills, and they do work. They do work very easily. So they just, the advantage is that there are more opportunities. It's that they will have to live with that for longer. My patients have a target of 100 years.
I think we need to cut things short, and I really appreciate the discussion. And that there is one point that we were always taught as patients, and it still happens in the early days. I remember 10, 15 years ago, don't think about what treatment you might need in your immediate future, because by the time you may need treatment, there might be something else as standard of care at that time. So therefore, you know, as a younger person, I was diagnosed, I believed in that, and it's still happening today. You know, without a doubt, 10 years on from when I was diagnosed as a 49-year-old, the treatment landscape is totally different now. I would have never recognized any of the treatments that are available now. So
I'm telling you the story of these weeks. There was an individual who had several treatments, a very aggressive transformation. He had the most aggressive type of immunochemotherapy you could think of. It was just water under the bridge, other than adding toxicity. We had a trial now here with another type of medication, little toxicity. Those huge, big masses that dislocated their neck disappeared like snow under the sun with tablets. I'm not going to say what it is. I'm not going to, because but to say your point is very, very, very much true. There are evolutions that are changing constantly and rapidly compared to the speed of CLL, which is slow. So I'm definitely buying what you're saying because it's true.
Thank you for that. I think that's an important message, really, is, hope and understanding that a diagnosis of CLL isn't the end of the world,
No.
that, so from that point of view, it was good to be able to share that information, and thank you. Bryony, last question over to yourself from a supportive care point of view. If you had time to think about and reflect on, if there's anything you'd like to add before I share a few slides for everybody to share some information that's available.
I think just to encourage people to know that they're not alone in this. They've got a team and charity support. So yeah, don't suffer in silence and seek help, because there is a lot out there for you.
Thank you for that. I think that's the important point, is you don't have to walk this walk alone. And there are many people, including the care team, the charities themselves, and patients who are linked into the charities by various routes to actually help with sharing lessons learned and understanding and how others cope. I think that's important. So I'm going to see if I can find these slides. And as usual, I struggle to find them, but I believe I have found them. Apologies. Okay, so whilst we're looking at information, obviously webinars is something that we at Leukemia Care frequently provide, and hopefully today's has been of some information and help, but at least it's stirred some thoughts that can point you towards more information. That I can give you some indications here where you can find. Leukemia Care, for example, we do offer and provide regular newsletters and a quarterly magazine, which is always worth a read, so that you can actually pick up on the experience of other patients that you might find uplifting and interesting. And then there are other general topics. We do run other services like podcasts, social media. We're very active, and the website is a mine of information for you to visit. I think there's been a few questions that could probably be helped by accessing some up-to-date booklets. So we provide a plethora of information booklets for patients, but we do have some very specific ones now around active monitoring and watch and wait in CLL, and also about CLL itself, to get a little bit more understanding. The most important thing really is the more information you have, the more able you are to carry out, to engage in shared discussions with your healthcare team, and the more understanding you may have over what is a very counterintuitive situation. Living on active monitoring with a leukemia, but nobody's doing anything, can be very hard to carry alone. But information is a good starting point, and obviously read information at a pace that suits you. You don't need to absorb it all. It might go over your head in the beginning. Just take your time. I touched on our regular magazine. That's our quarterly magazine that will be, you can register for that on the line. Now, most importantly, support. As our great panelist Francesco has pointed out, that available support by your healthcare provider and different hospitals varies. Charities are there to help with giving you that support that you might not be able to get. So at Leukemia Care, my colleague that's been helping me today, looks after, we have a team looking after our helpline. You can also contact anonymously and use a WhatsApp service. You can pick all this information up from the website. We also have a large range of virtual support groups, and those are now becoming in person for those that are able to be confident to do so. We provide welfare advice, advocacy support, online forums, Facebook groups, and a buddy scheme to help peer-to-peer support and counselling, and a counselling fund. I'll touch on some of those. So we do have fairly infrequent, but we have a national active monitoring watch and wait support group. That's where you can meet people at the moment digitally who can share experience on helping live under active monitoring and watch and wait. We have a national CLL support group, and we have, I don't know, 50, 60 plus, I'm not sure, I can't keep up to date at the moment, with national support groups so that you can discuss local issues and connect with people locally. You can find that information directly on the website, and you can register or you can contact the support team. If you're looking to actually connect with somebody else that is able to share with you and understands what's it about, we do have a buddy scheme. And again, you can either contact using the phone number, or contact us through the website. And our buddies are time served and are trained, and are there for you to be able to share experience and give you support. I talked about our advocacy caseworker. Sophie is actually giving us some support on the webinar today. Sophie's there to answer your advocacy queries, to help advocate for you personally, and help signpost and support and get you the information that you might need. So, you know, if you want to reach out and you're struggling, you know, that's an avenue for you. Everybody's being squeezed at the moment with financial hardship. We do have sorry, I'm struggling at the moment. We do have our officer who will, our welfare officer that looks after that area. So get in touch from that point of view, and there are a few grants that are available. I'm not sure what the situation with those is, Leukemia Care at the moment, but we touched on our Watch, Wait, Worry campaign. If you feel strongly and you feel that you're left out there to watch and wait and you're not getting the support you need, drop onto the website and have a look. As Bryony pointed out there, you can get in touch. We're actually, I think we've got petitions running to try and raise the level of support that's offered to this group of patients as a whole. And there's lots of other strategies to help you live and cope with active monitoring. If you're into fundraising and you'd like to put something back into the system, there's lots of opportunities to fundraise. There's some examples here of community fundraising. As we touched on earlier, we're very active on social media. If you're somebody that's out there yourselves, good information, you know, to keep tabs on things, use our social media channels. I'll leave this up here for you at the moment. If you're in need of support, if you want to contact us for any reason, here's our number: 088 01044, or contact support@leukemiacare.org.uk, and you will be connected immediately with our advocacy officer, who can then field and offer you the support. Listen, I've overrun dramatically today. I apologize. I'm normally a lot more concise than this. It was important that we were able to at least address some of the concerns that were being raised in the questions, and also to get to the bottom of some of the aspects around active monitoring. I hope it was helpful, and I'd just like to thank you, Francesco and Bryony, for giving your time this afternoon to help. And look forward to working with you again and seeing you soon. And thank you, everybody that's joined today's webinar.
Thank you, Nick. Thank you, everybody. Thank you, Bryony.
Thanks, Nick. Thanks, Francesco. Thanks, everyone.
Bye-bye, everybody.
Bye-bye.